It does not happen very often, but such cases have been reported in clinical practice. A patient comes into the dental office and calmly tells you, "Doctor, I think I swallowed my denture." At first glance, the situation may sound almost bizarre. However, after reading Dental Emergencies, edited by Mark Greenwood and Ian Corbett, I realized just how serious the consequences of swallowing or aspirating a removable partial denture can be. The key point is that a swallowed denture is not simply a lost prosthesis that will necessarily pass uneventfully through the gastrointestinal tract. A removable partial denture may contain metal clasps, sharp edges, and other components capable of traumatizing the tissues through which it passes. The authors note that ingestion or aspiration of removable partial dentures may occur more frequently in older adults and psychiatric patients, and they clearly emphasize that such an event should be regarded as a potentially serious medical emergency. For the dentist, the first critical distinction is already contained in the two possibilities described in the book. Ingestion and aspiration are not the same. If the denture has been aspirated, the problem is no longer primarily gastrointestinal. The foreign body has entered the respiratory tract, and the situation must be regarded as a potential threat to the airway. If the denture has been swallowed, however, the danger is not automatically over. The authors describe potential complications including laceration, perforation, and bleeding involving the esophagus and gastrointestinal tract. In other words, as the prosthesis progresses through the digestive tract, it may mechanically injure the wall of an organ. The possibility of perforation is particularly concerning. Once gastrointestinal contents gain access to tissues or spaces where they do not belong, what initially appears to be a localized mechanical problem may progress to a serious systemic complication. Among the possible consequences described in the book are peritonitis and septicemia, as well as foreign body granuloma formation and abscess development. These complications are rare in everyday dental practice, but they are certainly possible. That is precisely why one of the greatest mistakes we can make is to trivialize the situation. The patient may have no dramatic symptoms at the time they report what has happened. However, the absence of severe symptoms does not reliably indicate where the prosthesis is located or what damage it may cause during its subsequent passage. There is another clinically important point. If a patient tells us that the denture has simply disappeared, we should not automatically assume that it has been swallowed. Aspiration must also be considered. In an emergency, an unverified assumption may become one of the greatest obstacles to appropriate management. In its sections dealing with medical emergencies, Dental Emergencies specifically addresses choking and aspiration, further emphasizing how seriously dentists should take the disappearance of a prosthetic appliance during treatment or routine daily use. For me, this topic is important for another reason as well. We usually evaluate prosthetic restorations in terms of function, stability, retention, aesthetics, and patient comfort. However, once a removable prosthesis loses its stability, the problem is no longer exclusively prosthodontic. An appliance that until yesterday allowed the patient to chew normally can suddenly become a foreign body within the respiratory or gastrointestinal tract. For that reason, the statement, "The patient swallowed the denture," should neither provoke amusement nor lead to the automatic assumption that the problem will resolve spontaneously through natural passage. The situation requires serious clinical assessment, and the patient should be referred promptly for appropriate medical evaluation and further management.